Welcome, everyone. Thank you for joining us for today's Sight and Sound Bites webinar. My name is Carrie Fogel. I'm the Senior Director of Development for Foundation Relations here at the Eye Foundation. And as you know, every month we do a few of these webinars focused on different topics related to vision loss, hearing loss, head and neck cancer and surgery, sinus allergy, balance disorders, and conditions of the voice, and many more. One thing you can always count on is that we are always staying on the cutting edge of technology and science. So today's topic exemplifies just that. We're excited to present the webinar on mandibular and maxillary 3D modeling in head and neck reconstruction. Our speaker today is Dr. Matthew Spector. A quick reminder before I introduce our speaker, we aren't using the chat function for questions. But if you do have questions to submit to Dr. Spector at any point during the presentation, please feel free to submit them in the Q&A box, and I will moderate the discussion following the presentation with Dr. Spector. I'll try to get to all of them. If, however, I run out of time and I'm not able to ask all the questions that are asked today during the presentation, we will make sure to get the answers sent to you via email. Dr. Spector will help us answer those. Following the presentation today, there will also be a video of the webinar uploaded on the Eye Foundation website, and you can access that as soon as it is available, probably in the next day or two. So please let me introduce our speaker. Dr. Matthew Spector is the Division Chief of Head and Neck Surgery in the Department of Otolaryngology at the University of Pittsburgh. Prior to his joining the department last fall, he was on faculty at the University of Michigan for more than 10 years, where he served as the Director of Head and Neck Oncology Program and the Associate Director of the Head and Neck Surgical Oncology and Microvascular Reconstruction Fellowship. Dr. Spector specializes in all aspects of extirpative head and neck surgical oncology and head and neck reconstruction. His research interests relate to both clinical and translational questions in head and neck oncology and head and neck reconstruction. He is primarily interested in improving the overall survival of patients with head and neck cancer through outcomes and research to improve patient selection and prediction of response to therapy. We're thrilled to have him. He's been a great addition to the department. He's working very hard. So please take it away, Dr. Spector, and look forward to a great discussion.
Thanks, Carrie. Can you hear me okay?
I can hear you good.
Perfect. All right. Well, welcome. Thanks for sharing your lunch with us for our webinar. This is my second one of these, and so I'm still getting used to kind of talking without seeing everybody. But if you have any questions, please send them in. I'd love to chat further about this. I picked this topic because this is one of the toughest things that I have to do as a surgeon. And so again, Carrie gave a great overview. Obviously there's the cancer part. We want to, defeat cancer, right? And make sure we're getting the best possible outcomes. But then after cancer, like what is there and what happens? And so, we have to do reconstructive surgery. We have to be able to restore speaking and swallowing. We have to restore facial contours. We have to, restore quality of life. And so one of those big topics is reconstruction of the maxilla and the mandible. And a big thing that's changed in that in the last 10 to 15 years is kind of this new 3D modeling technology. So with that being said, let's see if I can come through here. We really have two learning objectives today. We're going to talk about the complexities of mandibular and maxillary reconstruction. And I'm going to show you some kind of cool pictures of how 3D modeling has really changed the game for us. This is a patient from a few months ago. We're going to use this as an example most of the time, so I can show you on the models. But you can see, everything about this is complicated. Kind of restoring some of these shapes with this plate that we'll talk about, getting new teeth, and so there's a lot of little pieces of this. The most common reason we need to do this type of surgery is basically for cancer. And so most commonly we're rebuilding a jaw or the maxilla for a cancer defect, but we do see patients with trauma who come in that we have to do some of these similar surgeries. We also have some congenital defects that we do too, but they're fairly uncommon to do something this. And again, I think this is the way I kind of lead into this, especially when we're talking to a patient. It's think about the complexity of your face. Every day you wake up, you look in the mirror, you wash your face, you eat and drink, and you speak to other people. And so the kind of the way you see yourself really is kind of everything about what you look in the mirror. And so those are things that I think about when we're trying to, rebuild the facial contour or work on speaking and swallowing. Even breathing, having a patent airway can be important for some of these questions. And so, take a moment to think and look at this picture, right? So this is a skull, right? And this is made from a CT scan. So we're able to take a CT scan, run it through software, and build this 3D model. And so I have lots of these, right? These are how I think about kind of people and how we're rebuilding things. And so you can see I get these made to really understand the three-dimensional anatomy and how I'm gonna be able to take care of something like this. In this case, you can see we're missing some teeth, right? There's missing teeth on the right here. We're missing part of the cheek, right? This red represents a gap in the floor here, or the orbital floor. So you can see there's a hole here. And so that has to go into kind of thinking about how you're going to rebuild something like this. And so when this patient came to me, she'd already had surgery, but they didn't do any reconstruction. And so it was a gap in the teeth. A cheek was depressed in right there. There's a hole in the floor here, the orbit. So those are all things that I had to think about to get this fixed. And so how do we think about these things? And so this is our reconstructive ladder. I used this on the last webinar that I used, but this is the way reconstructive surgeons think about how we're doing things. And so what secondary attention means is you have a cut or a gap or a hole or some injury, and you just let kind of things heal in on their own. Primary closure, primary intention can mean you sew it back together. And a lot of these things you can't sew up, right? So this picture I showed you before, there's nothing to sew here. And so we kind of move very quickly up the reconstructive ladder to free tissue transfer. And so what that means is I'm taking bone or skin or fat or muscle from one part of the body and putting it in this area to rebuild the jaw or the maxilla. And you can't really use cadaver bone in this area. You can't use, a loved one or a friend or a cousin's bone. It has to be your tissue so you don't reject it. And so free tissue transfer, again, is one of your bones that goes to rebuild this area. And here's the two main examples of bones that we use. And so this is the fibula. This is the bone on the outside of your leg. We use this commonly to rebuild things. And then this is the scapula. And so this is my personal favorite. I think it's a little easier to use than a fibula. I think patients recover a little better from a scapula as opposed to a fibula. I think that the bone shape and the curvature reminds me of a jaw a bit more. And so those are reasons why, and I'll show you some pictures of how I've thought about it and how my research has been designed around some of this over the years. So we know we need bone, right? So we need one of these bones to rebuild these. And then we got to figure out how to do the modeling. And so I stole this one from the internet, but this is kind of how we think about the different types of modeling these days. And so everything that we had used to be machined. So it's this machine, CNC is a computer, right? So a computer takes a block of plastic, metal, whatever you want to take, and it takes the block and it can shrink it down by machining it, and it creates something out of that. And so a lot of types of the plates that we use used to be machined. And so you just kind of take a big piece and you turn it into a little piece. 3D printing is exactly the opposite. So what they do is they take one of these models, or however they want, they start layer by layer, and they can build up layer by layer. So it's an additive type of manufacturing to put layers on. The benefit of 3D printing is that you're always able to do more complex shapes. Like machining, when you drill it down, you only have certain angles you can go. But when you build something with 3D printing, then you can build a more complex shape. And this is a bit what it looks like. And so this plate that you're looking at here, this is a titanium plate. It's 2.5 millimeters thick, but it's very simple, right? It's a very simple plate. It can go kind of up and down and left and right. And these plates were machined. So you can see where they could take a machine, you cut out of a block of titanium, and you can see that it would go down like this. And so this model here, right, which I use, this is a patient's mandible. And you can see this mark is where the tumor is, and these are kind of the planned cuts of how I think through it. Something like this isn't machined, right? It's too complex. It's got too many kind of edges and curves, and it's really bent and it's super thin. So this is a 3D printed titanium that we use for implants. And so again, for her, right, I was thinking, well, how am I gonna rebuild this and restore everything that she wants? And so that's what we talk about in the clinic. And so if I, when we meet patients and I talk to them, I say, well, what is the thing that you want most out of this reconstruction? And these are some very common things that I hear, right? So every time, she was drinking, you can see there's a hole here. So it would go up in the nose. And so just, again, oral nasal separation. It sounds so simple, but being able to drink something and it goes in the right spot. Her eye felt a little lower on that side. So we got to bring the eye up a little bit. So getting everything healed. So she didn't need radiation, but sometimes patients need radiation after surgery. And so, you can't just have a wound or something here that you can't get radiation. The cheek, you can see this bone right here. This is called the piriform aperture. That's gone on this side. So to hold everything out, we have to rebuild those points too. And so, these are all things. And then finally, the dentition, right? Obviously, there's no teeth. So, hey, can I have teeth again, whether it be smile teeth or chewing teeth? So those are all things I think about in some of these complex reconstructions, and we talk about it. And some people kind of tell me other things, right? I want something different. I'd rather have my eye here than have more teeth, or I don't really mind not having teeth. If you're a edentulous already, maybe teeth aren't as important. So I found these so difficult. I found that mentoring residents and fellows and teaching them was tough. And so I started to write papers on this to try to figure out how to teach them how to do things. And so this paper I wrote a couple of years ago. It's probably 3 years old now, but this still stands true today. And so we thought about how to rebuild an orbit. So, right, there's things we've talked about for goals, right? Supporting the eye, getting teeth back, having the cheek projected. And so I mentored, a resident on this project to say, well, how can we do things like this? Or what's the best way to do it? And what we found is that the scapular bone of that shoulder blade is the best way. And so this is like a diagram of that. So this is someone laying on their back and their left hand is in the air there. And so the head would normally be up here and then the hips are down here. And we're looking right at the shoulder blade. This is actually a surgeon's eye view. So we usually sit down when we're doing this and we're looking at the shoulder blade, and this is what it looks like. And so we actually take the tip of the shoulder blade off. It has a really good blood supply. These red lines represent the arteries going to them. And we take that off. You actually don't need this part of your shoulder blade. You'll have normal shoulder function after this. So even though we take a little bit of the muscle with it, the muscles that are left kind of supply the rotator cuff and you have normal function. But yeah, you take this little piece of the muscle and then you can fold it a couple of ways. And so this is one way to do it, right? So if we take this out, like in our index patient, those skulls that I showed you, we can take that piece of the shoulder blade out. And in this paper, we showed that we could fold it right on the tip of its axis. And so you can reconstruct both the mouth, right? So there's a chewing surface and it seals the nose off. And you can reconstruct the face of the maxilla, which gives you projection so you look normal. I know this is a little crazy, but you're obviously working under the lip and all these things. And so we've lifted all this up, we put this in, and then we pull everything back down. So patients look very normal after this surgery. Another type, so obviously this involves, the face of the maxilla or the cheek projection and then the teeth. Sometimes they're higher up. So this is involving like the bone under the eye and here. And so this patient's like, well, what if my eye falls? Or what if I have, double vision? We showed that we could take this scapula and put it in the other way. So instead of rebuilding the teeth and the gums for separation of the mouth, we could reconstruct the cheek on this surface so they look normal afterward. And then the eye was supported by this little fold right here. And so that the eye looks normal when you look them in and they have no double vision. So this type of study, this is one way I'm able to teach my residents and fellows, how do you redo these and what's the best way to do them? I did the same thing. I don't have as cool of pictures. I did this, this was later. This is like a year before this paper that I wrote. So this one was doing the same exact thing, but looking at the mandible. I just didn't have a good of an artist rendition. When I worked with Dr. Herring, she was one of my residents. She was great, but she helped me draw a lot of these and really show it. So I need to find a new resident or fellow to help me with the drawings on these. And so this is looking at the jaw. So this is a jawbone that you're looking at. You're looking at these are where the condyles are, or you kind of are up here, and then this is where the teeth would be. And then this is that shoulder blade. And so then what you do is we overlaid these. So we took A shows the jaw, B is the shoulder blade, then we put them on top of each other, right? And so the computer modeling did this so we could show how can we rebuild the jawbone with part of the shoulder blade. Here I'm showing where we took out a piece of the jawbone on the overlay, so you can see how nicely the curvature of the scapula fits in here. And so this was important because then I can say, okay, well, I'm rebuilding this person's jaw. And if I take this piece of bone out of the jaw for cancer or whatnot, then we can put this piece of bone in and it fits really perfectly. And then they'll have normal projection of the jaw. They'll have separation of the mouth. They'll have a masticatory surface. And so, again, this paper is what I use to teach them about mandible reconstruction and showing how nice the scapular curvature is. And then, the complicated ones are these. And so, everything I showed you is kind of 3D modeling, right? I can get these models made and I can really kind of show patients and residents and fellows how to get these nice shapes. But this is 3D printing of metal. And so here we contract with a company called KLS Martin. They actually can build me these plates. And so I get on with one of their engineers and I can kind of design how I want the plates to go, where the projection points are, right? So obviously, again, we want the cheek to stick out, so we can build a plate that holds the cheek out here. We want the eye to be supported, so we build this. And then this one has dental implants built into it. And so here we could put a dental implant in at the time of surgery so that the patient wakes up with all the things that we talked about, right? Projection of the midface and facial contour, support of the eye, separation of the oral nasal cavity, and then dentition for smile teeth or chewing. So yeah, that's kind of all the options. So when we take these pieces, we really kind of figure out what fits best for each person. I'll show you. So again, these advantages, right? I could build almost any plate that I want with these 3D modelings. It's called either IPS or virtual planning. That's these individual patient solutions that we're using. If you look at studies using this type of technique versus other techniques, this is not only a little bit quicker in the operating room, but cost is lower from all this. Even though we have these kind of expensive models, we're able to do it this way. And finally, I'm able to educate my residents and fellows. So, they obviously start their practice after they work with me, they're ready to do these things as well. I have a couple of case examples, and I wanted to keep this short on purpose because I was hoping I could have some questions and answer time with everybody. This is a mandible reconstruction. And so again, there was a tumor at the bottom of the mouth here, so right next to the jaw, and it eroded the jawbone a little bit. And that's what this is right here. So this is the jawbone in 2 different cuts, and you can see that the bone is eroded right there. And so in these types of cancers, when the bone is eroded, and it's a really, you have to take out the entire bone. You just can't shave it down. And so that's one thing that we think about when we do these surgeries. So here's that same models that I showed you before. So back with this patient, I was able to bend this myself. So you can see the tumor was right on the inside of the jaw there. We take these plates and we put them to span that defect. So we have a little bit of the jaw, on one side free and on the other, so we can put this plate on to hold everything together. That helps me keep the teeth in occlusion, right? Because you want to be able to bite after all this. And if you don't put the plate on first, you can have a problem. And then I have a model made like this. So this is a shoulder blade model of the same person. So this is called the lateral border of the shoulder blade. And so I'm able to take this piece of bone right here and plan everything out with the models. So this is the piece I'm going to take. Then I can put it in the fixed defect here. So you can see, like, I could put these models into where it's going. So you can see everything's all planned out on the back table. And here's another picture of it. So you can see that new piece of curved bone that's going to be the new jawbone sits in there just like that. These arrows represent where the artery and vein are coming, right? Because we're taking a new artery and vein, but we're able to run it off the back here to go to the neck with this. And so my next picture is gross, so I want to warn everybody ahead of time. That's what this looks like. And so you take this tumor out. So here's the tumor out, and the tumor was right under the jawbone here. Then you take this bone, and this is actually the piece of bone. I know it's crazy, but it's covered in that little, like a thin layer of muscle. And in this case, I took a piece of skin with it. So here's that plate on that you can see. Here's the new bone in underneath here. And here's the new blood supply, the artery and the vein that we're going to hook up to rebuild the jaw in this case. Again, another gross picture. Right when we're done with surgery, this is what it looks like. Everything's swollen, the new piece of skin's in there. And then you wait 6 months. And then again, it's really important that I counsel people, you got to give this time. It's going to take time to heal. When you get a knee done, you don't run out of the hospital, right? Or a hip, you have to rehab it. And so, this young person did swallowing and speech exercises. And after 6 months after her radiation, I mean, she's got normal tongue movement. She eats and drinks in public. She has a regular diet, and she's got this new skin in here, but her jawbone and her facial contour are all normal. So this is the ideal result for this. I have one more example for you. Obviously, that was a jawbone. This is of the maxilla. And so this is a young woman. I met her when she was 16, and her dentist found a tumor of her top, like her hard palate. So we're looking in her mouth on the right, and you can see there's a lump here, right? And that's the tumor of the hard palate. This is her CAT scan. So remember, the way we build these 3D models are on CAT scans, and you can see if you look at, this is her left maxilla. So this is the nose, these are the eyes, this is that spot on the back right of her mouth right here. And you can see the bone is scalloped here. So there's some erosion of that bone. So we know we're going to have to take out some of the teeth in that area and the back piece here. Here's her model, right? So I have her model flipped up. So we're looking kind of up into her mouth with this. The pink ones are all of her teeth here. She actually had braces on. If you see these are her braces that had when she had the scan done. They had her braces with it. And then I marked out the tumor very clearly. And then you have to get a margin. So you have to take a little extra is what that shows. And then, so here's her models. And so this is her scapula, right? And so this piece of bone is what we took out here to rebuild the maxilla. And so I took this piece of bone out with its blood supply. It's going to go in this spot. You can see you can almost fit it perfectly just by doing this. And then there's the resected piece I cut out of the plastic. Another gross picture. We're looking in her mouth. So you're looking directly in the mouth, and you're looking right up into the nose, actually, because after we took that out, this is what you see. Here's that piece on the back table, right? So we said we always get a little piece of muscle around it. And so you get a little, there's muscle here with the bone. You have the artery and the vein, and it measures up to this right here. So they're symmetric. And then here it is kind of on there. So again, I kind of try to show that this piece of new bone and muscle we're taking is going to fit on the back of the teeth here. And here's the artery and the vein. I know it sounds crazy, but this is what it looks like when you're done, right? It looks really raw and it's kind of rough looking. But if you wait 1 week, it looks like this. And so it's pretty darn good, and it's almost already healed. This is actually a month. So this is a month out. And then this is 6 months out. So you can see it completely heals here. I need to get new pictures of her. She now has teeth in this area. She got dental implants. And so that's the next step. But you can see how kind of well this heals up. Even if you didn't have kind of the financial resources for dental implants, this can be done. So one more example. This is a harder one, right? So this is in the front of the teeth here. And so you can see the tumor involves around this bridge and veneers here. And so the tumor was right up in the front. But we can do the same exact kind of steps with this. So here's that model, right? I'm able to get these models made. And then I made the cut right off the model of where the tumor was. So I knew exactly what the defect was going to like, and then be able to make my plan for all this. This right here is the resected, right? The resected teeth. You can see where the tumor was with all the margins. Here's everything on the back table again with everything cut off. So here's the piece I took off. Here's what the defect looks like. And then here's the tip of the scapula. So again, I can take this little piece off that I like. This has the right shape and size to rebuild all this. Unfortunately, I was in the wrong focal depth with this picture, but it's the only one I had. So you try to take as many pictures as possible, but you always never have the one sometimes that you need. But this is everything sewn in after the surgery. And here's what it looks like after a month. And so you can see the everything kind of heals up and mucosalizes over, and it gets ready for dental implants at some point. So, well, that is the complications of these types of reconstruction. I'm very excited. I have, because of my interest in this and the support of the University of Pittsburgh, I have a course coming up. So that's courses designed for fellows that kind of want a little extra training before they're done. So a fellowship usually runs from July 1 to June 30th. And so this course is June 1st. So we've asked fellows from all around the country. We're going to take about 50 fellows, and they're going to come in and learn some of these techniques at the University of Pittsburgh that we're doing here. And so I'm excited. This is the first year of the course, and we're super excited to do it. So.
Well, thank you so much. That was really, really interesting. I didn't know a lot of the different techniques that you go about building new parts of the maxilla and the mandible and the jaw and the entire head and face. So great work. We do have several questions. I will go ahead and start asking, but I want to encourage anyone who's still online, if you have any questions that you're thinking of now, we will have time to answer them in the hour. And so I'll go ahead and get started. So we have someone who said, this is all so amazing. Will you eventually be able to print bone itself, perhaps using stem cells with 3D printing?
Yeah, so that's a great question. So we can 3D print scaffolds right now that tissue can grow into. So like tissue scaffolds. So you could build a shape. Let's say you wanted to make it like an ear, and then you can put cartilage in there. We know those cartilage cells can grow. And so there's definitely some steps we're missing. Like we're not quite there to take your cartilage and put the right whatever formula on it to let it grow into, into a full ear or the shape or how to make it grow in the right direction. But we do definitely have some scaffolding that we can print that the tissue can grow into. But I think you're exactly right. In 10 years, the things we'll be able to print are probably going to be, using someone's own tissue to do that. So.
Thank you. You cited a few examples where you used titanium to kind of rebuild some parts of the jaw. How long can titanium stay in your body? Does it ever degrade? Does it ever cause problems?
Titanium's really good. So not everything is perfect, but there's some metals that are very inert, right? And so nickel's the opposite, right? You get nickel earrings, and then they can have a lot of reaction. That's probably the most common metal that people know they have a reaction to. But things like gold, we use gold or platinum sometimes for eyelids to help people blink. And then titanium for plates. Most people don't have a titanium allergy or reject these types of plates. These are fairly new. We used to use steel. So in the 90s, they used steel plates, and those were much more problematic. But the titanium plates we're using are pretty darn good.
So I noticed in several of the examples you talked about that you work a lot, in all parts of the face and some parts in the eye. So that led me to wonder, what other specialties of surgery do you work with, like across disciplines, across different areas?
That's one of the right. That's one of the best parts of my job. So when I work on kind of things near the brain, so let's say there's tumors or reconstructive surgeries up here, I'll work with neurosurgeons. Things down near the spine or the upper esophagus, we work with our thoracic surgery colleagues. I work with my oral maxillofacial surgeons for dental implants. So when we're talking about that, I work with an oral surgeon to help plan things and make sure we're doing the right dental rehabilitation. There's going to be more. Now, I've worked with vascular surgery before. So with complex tumors of the neck, we work with our vascular surgeons to take out tumors there. I work with orthopedic surgeons. So last week, I had a young gentleman who needed a piece of bone from the arm that we use, which is much less common. And so obviously the scapula and the fibula I talked about are the most common, but you can actually take a piece of this bone too. And for him, this was the best site for him. And so I had orthopedics come in there with me just to plate the arm afterward, because the other ones don't need plates, but this one does. And so he helped me plate the arm to get everything, to make sure he had a good, strong wrist and hand function afterward.
So speaking of taking bone, the patients that you use the scapular bone to kind of do some of this reconstruction, do they have any long-term effects or restrictions or side effects from missing that part of their body?
So interestingly, yeah, that's a very common question, and it's much, much less than you think. And so if you look at people who get scapular bone versus fibular bones can cause a bit more problems with walking and getting around and mobility. Whereas the shoulder blade, if people are using it enough and they go to rehab, you get very normal function. I think it's because I'm looking for a scapula model on my desk here. That's why I'm looking around. The tip of the scapula, right? All the muscles like run down the scapula to insert on the rotator cuff muscles. We're just taking off a little bit of the bottom of it, and then those muscles fuse back together, and then you get really, really normal function. So it's much less than you think, and people have very normal activities afterward.
So, for myself and anyone else on this presentation who doesn't know, with the 3D printing models, do you do those on site here at the University of Pittsburgh? Do you work with companies for some of these more complex models that you have to do? How does that process work when you are in a university setting like this?
Yeah, so luckily I work at an institution that can do all the models, the plastic models I showed you internally. So UPMC has a whole Department of Radiology who employs engineers, and I work with their engineering group to get these made and to have them for surgeries. We can't print metal yet, so a titanium metal printer, some of this picture that I show here with this very complicated plate, those have to be done through a company. And so I use KLS Martin, who's been doing this for a long time. It's a German company that they're able to 3D print these titanium plates for me. I think also in 5 to 10 years, we may be printing these in-house as well. But right now, I mean, they're able to do such a good job, and we don't have the capabilities. We use them.
So for some of these, like the one that you're highlighting right now on the screen, these really complicated reconstruction cases, what kind of rehab, other services do they sometimes require after, you're taking out large parts of the mouth and face?
Yeah, there's a lot. So we have a huge team here, right? So it starts with speech and language pathology is probably the first one that makes the most sense. Like, right, again, like you get a knee or a hip done and you see a physical therapist, right, to work with you on those. And so our speech and language team for speaking and swallowing, everything you would need to kind of rehab your mouth, they work on. You see a physical therapist as well, right, to work on shoulder mobility. You'll see a nutritionist typically, right? So it's hard to get nutrition after some of these surgeries. And so sometimes you have a feeding tube and sometimes you don't, but nutrition can be a really important part of that. We have a social work team, right? And so sometimes that involves psychologists. So think about, you can look very different after these surgeries sometimes. So coping with that with you and your family can be something that's really important too. And I know I've missed part of my teams too. We basically have every resource you could possibly need if something comes up, but those are the major ones that we think of.
We have one question from one of our audience members wondering how many surgeons are trained like you to do these complex reconstructive surgeries.
I train 2 fellows a year, and then there's 5 residents a year that graduate. Usually you do a fellowship for this. You do 5 years of residency and then 1 or 2 years of fellowship afterward. Not everybody does a lot of these. You kind of migrate into the things that you like to do. And this is something I really, I take pride in my work with these and thinking about these problems. And so there's about 70 fellowships in the country. And so we train about 100 to 120 surgeons every year to do similar things, but they don't always do all this work. They may specialize in something else or move into a different area.
Someone else has asked, how do you know for each patient where the best place to take bone or tissue is from? What are the qualities that you're looking for?
Yeah, it's a tough conversation. It depends on a number of questions. I can give you them in no particular order. Your handedness, so left-handed or right-handed. If you're right-handed, I typically take from your left side and vice versa. just because people are more used to using their right shoulder and right arm. So if you're trying to draw or write or comb your hair or brush your teeth, it's a little easier to do it on your opposite side. Everyone's got a different occupation. And so I'll give you some examples that are easy. So I operate on a police officer who used to have to walk 6 miles every night. He had a night shift where he wanted to walk around the whole time. So we avoided his leg because he had to walk 6 miles a night and he didn't want to have any problems with it. And not that it's a huge problem for walking, but if you're trying to, if that's your job, that's what you're doing, that's something we think about. I've had occupational therapists. So they use a lot of shoulder and arm strength to help move people and transfers and things. And so she wanted to use a leg as opposed to a shoulder or an arm because it's just a lot more work. And so there's people who love walking, there's people who love gardening, there's people who love knitting. And so whatever your hobby or occupation or the thing that you use most, I typically try to, use the area that you don't need as much, although it's not always a huge problem. It's just nice not to have to think and get back to your hobbies or occupation right away.
Great. So we have one more question, and then I'll probably wrap it up, but want to encourage everybody that if you think of something after the fact that you'd like Dr. Spector to weigh in on, please, you can feel free to email myself or Craig Smith at the Eye and Ear Foundation at any point. But this is regarding one of the case examples that you showed, asking if the patient that you were talking about is truly 16 years old and any thoughts about the cause of a cancer in such a person who's so young.
Yeah, it's bad luck for her, and she got lucky to catch it early with her dentist noticing something different. It's not, obviously you can think of things that you are related to cancer, right? Smoking and alcohol, and it's not those things. The HPV virus can be related to cancer. It's not that either, right? That takes 30 or 40 years, and usually people present in their 50s. And so this was something called a salivary gland cancer, which was just bad luck for her. And luckily, I did her more than 5 years ago. She's doing fantastic. She still sends me a little note when she's in college in the winter to tell me how things are going. But luckily for her, it was just, again, it was bad luck, and she did really, really well from it.
That's great. Someone, with bad luck who's so young with all of life ahead of her, just, can continue a normal life after that. So I think we don't have any more questions at this point. But like I said, if you have anything after the fact that you're thinking of for Dr. Spector or anyone at the Eye and Ear Foundation, you can feel free to submit them to our emails. I want to thank Dr. Spector for a really interesting, little gory presentation today, but I think we all expect that at this point. And I want to wish everyone a great afternoon, a nice weekend, and thank you all for being here today.